coming this morning, and I'd like to thank Dr. Saban for inviting me to speak on breast reconstruction, as well as AstraZeneca for sponsoring this event. So, I'm sure many of you have already completed reconstruction. Hopefully this talk will help to increase your knowledge about reconstructive options, as well as provide some information on newer technology. This is meant to be a brief but very broad overview on options in reconstruction. And for the patient who is facing reconstruction, it can be quite a daunting experience. The myriad of options is very confusing for many patients, and for some patients, it's really just not for them. So I usually recommend that all patients consider prosthetics first. Prosthetics have come a long way, and it is important for all patients with breast cancer to know what they're like, imagine what it's like to wear them at different times of the year and under different social events, so that they can gain perspective as to whether this is something that's right for them or whether they should be thinking about reconstruction. For those who are pursuing breast conservation therapy, such as lumpectomy and radiation, the development of oncoplastic technique affords a way of achieving better symmetry without having to undergo a full mastectomy and the reconstruction that follows that. This is a patient who underwent a lumpectomy for ductal carcinoma in situ of the right breast, and then, and then elected to undergo a reduction mamoplasty for both sides to achieve better symmetry. This patient had previous breast conservation therapy, and that consisted of a lumpectomy in the right breast, followed by radiation, and this distorted her nipple line. She also experienced shrinkage of the breast with radiation, and she presented to me for options for symmetry. And nowadays we can use fat grafting, as well as application of acellular dermal matrix or alloderm and other companies' products to improve the contour of the breast and relieve some of the radiation-related contracture. She underwent alloderm grafting and nipple repositioning for the right breast and a contralateral reduction mamoplasty for symmetry. Implants are definitely the most popular method of reconstruction at the present time. For a long time, silicone implants have been off the market, and in 2000, the FDA brought them back on board after several large-scale multi-center studies were done that showed that use of silicone or saline implants were not statistically associated with any sort of autoimmune disorders. In general, silicone implants provide a more cosmetic result with a smoother contour and less rippling, but saline options still exist. A lot of patients would like to undergo an immediate reconstruction where the mastectomy is performed and the implant is placed at the same time as the reconstruction. And in certain patients with the right soft tissue envelope, this is a possibility. This patient underwent a left mastectomy with an immediate reconstruction followed by nipple reconstruction and tattooing and a contralateral reduction mamoplasty for symmetry. It is important that you remember that immediate reconstruction is not for everybody. And while it sounds simple, it is actually sometimes more complicated than you think. Immediate reconstructions often require secondary revision procedures or contralateral balancing procedures to achieve a desirable look. And it's hard for patients who've never had implants in particular to understand exactly what size might be appropriate for their particular breast pocket after mastectomy. I give you this as an example. This patient is a fairly small-breasted woman, and she thought that she would like to be slightly more endowed, if possible, after her reconstruction. And she was a typical mother of two, had lost a lot of volume in her breasts, and elected to undergo an immediate reconstruction. The surgeon's hands are somewhat tied. You have to fill this somewhat lax breast skin pocket with whatever implant will take up that dead space. And sometimes it can be larger than what the original breast volume was. And so, depending on the patient's mindset and mind frame, that may be somewhat of a surprise when they wake up after surgery. Nipple-sparing mastectomies are becoming much more popular, particularly for patients who have either non-invasive breast cancer or who are undergoing prophylactic mastectomy for BRCA positivity. This patient had a very strong family history of breast cancer. Virtually every female in her family had breast cancer, and she elected to undergo bilateral mastectomy with nipple-sparing mastectomy. It's important to remember that the nipples are not sensate. They are not innervated after mastectomy, and so they will not contract or behave like normal nipples. She elected to use the opportunity to try to increase her breast size and had expanders placed at the time of her initial mastectomy, followed by later silicone implant placement. But this is actually a great technique for people who want to have a one-stage immediate reconstruction, have enough padding, soft tissue, fat, and skin to cover their implant nicely, and the use of silicone implants really achieves a nice look. Tissue expanders as a first stage is probably the most commonly performed procedure in breast reconstruction today. Tissue expanders are temporary water balloons that are placed beneath the chest, skin, and pectoralis muscle. The bottom half of the expander requires some other coverage, which can be in the form of acellular dermal matrix or alloderm, or a muscle flap. Alloderm is currently very popular because of its elastic qualities. It will allow the bottom hole of the breast to round out nicely with the expansion process, whereas traditional muscle flaps often will tend to scar and become restricted. The process can take up to 3 to 6 months to achieve final expansion, and sometimes has to be interrupted because of chemotherapy or radiation considerations. But it is a very useful technique to have, and allows the mastectomy skin flap to recover without the full weight of an implant behind it. These are examples of tissue expanders. And this is a patient who underwent bilateral mastectomy with tissue expander reconstruction, followed by later placement of implants and nipple reconstruction. If you are a patient who is facing radiation, known radiation in the future, and you want to have an implant type reconstruction, tissue expanders are definitely the way to go. The rigidity of the expander maintains the pocket to its full extent and resists the deformational forces created by radiation. This woman underwent a left-sided mastectomy followed by chemotherapy and radiation. And at the time of her mastectomy, she had a tissue expander placed with alloderm. A year later, following her adjuvant treatments, she underwent exchange of her expander for a final silicone implant. And we were able to maintain her projection volume to the extent that she desired. She also underwent a contralateral mastopexy for symmetry. For those of you who are more holistic in nature and for whom implants are not an option, autogenous reconstruction is a wonderful way to achieve a very symmetrical, very natural looking breast. And these come in 2 flavors, pedicle flaps versus free tissue transfer free flaps. The difference between the 2 is very simple. Pedicle flaps are basically flaps that are left attached to their original source of blood supply. And they are rotated on that blood supply, on that axis, and placed into the breast pocket through a tunnel underneath the skin. Free flaps are tissue transfers where you can view them basically as organ transplants. The tissue is actually detached from its blood supply, brought to the chest wall, placed into the mastectomy pocket, and then hooked up to blood vessels in the chest wall using microsurgery. And they come in a wide array. Everything from the buttock, the abdomen, to the thigh can be used as donor sites for free tissue transfer. And I'm just going to give you a few examples of some autogenous type reconstructions. The Latissimus Block is a workhorse for breast reconstruction that has been around for the last 40 years. It is based on a relatively minor muscle. It's a large flat muscle in the back, but the utility of that latissimus muscle is fairly low and can be replaced by other shoulder girdle muscles. This is a patient who had bilateral breast augmentation and then discovered a year later that she had a breast cancer in her left breast. She never had a mammogram prior to her breast augmentation. She presented to me and underwent a left mastectomy with immediate reconstruction using a Latissimus Block and tissue expander. She wanted to keep her opposite implant, and she wanted her breast to hang to the same degree that her right augmented breast did. And this is her after reconstruction with her final implant, nipple reconstruction and tattooing. In her case, we placed an expander because she wanted to have a fairly large implant, and the initial mastectomy skin pocket would never have been able to tolerate that weight. So an expander was used in her case. But in many patients, this can be performed as a one-stage reconstruction with an implant and a latissimus flap, and even the nipple reconstruction, all performed in one stage. The latissimus flap is a great tool for salvage and radiation treatment, and it is also great for secondary reconstruction as well. This patient was diagnosed with a locally advanced left breast cancer and underwent mastectomy with radiation treatment. And a year later, she presented to my office wanting to undergo breast reconstruction. And we looked at her opposite breast and we talked about whether or not she wanted to save that breast and try to match that. And ultimately, she decided that she wanted two brand new, nice, symmetrical breasts. So she underwent a mastectomy for that side, and at that time, she had a latissimus flap placed on the left breast, bilateral tissue expanders placed. These were expanded and then changed out to her final silicone implant result. This was then followed up with nipple reconstruction and later tattoo. And this is just an illustration between the difference between a pedicle flap from the abdomen versus a free flap. Immediate unilateral tram reconstruction. This is a very popular method of reconstruction, still performed by 70% of plastic surgeons in this country. It's a great hardy flap in the right patient. It can achieve very nice projection depending on the quality of their fat and completely obviate the need for implant reconstruction. This patient is a grandmother of 3 grandchildren that she liked to run around with and swim with, and she wanted to stay active. I think a lot of patients have this misconception that if you have a tram flap, that you'll become some sort of abdominal cripple. I think that that is the case when the abdominal wall is not repaired properly. You need to have a strong, sturdy repair done with by an experienced surgeon with good mesh for support. And with that, you can do pretty much all of your activities. And I've taken videos of patients who've had tram flaps. You can do sit-ups. You can do all the external oblique bar exercises in the gym that I can never do. They are amazing. This lady had a large lumpectomy in the right breast, first for biopsy and diagnosis, and she underwent a mastectomy with an immediate tram flap reconstruction and then later nipple reconstruction. She achieved a very satisfactory degree of symmetry. You can even have a bilateral tram flap, so if you're willing to give up both six-pack muscles, you can make 2 breasts. Again, even especially for a bilateral tram flap, that mesh repair is particularly critical to maintain abdominal wall mechanics and form. And in the right patient, the tram flap, if it is not too fatty and not too large, it can actually tolerate radiation quite well and maintain its volume as well as its shape. Both of these patients have had radiation after tram flaps. Lastly, it's a great workhorse for secondary reconstruction as well because of the amount of skin that can be harvested to use in making a new breast. In terms of free flaps, I think that free flaps became very popularized in the period of time when silicone implants were not available. Simply because saline implant reconstruction just doesn't look very good. And so plastic surgeons started developing every imaginable free flap for breast reconstruction. And I think if you have the right donor site and the right match for the breast volume that you're trying to achieve, free flap reconstruction is wonderful, but it has its limitations. Most free flaps are fat and skin, and that doesn't necessarily provide a whole lot of anatomical support or connective tissue support to create a well-projected breast or a nicely shaped breast. So it really depends on each individual situation, what cup size you're trying to achieve, and what your available donor sites are. This patient was a BART train operator. She had previous bilateral implant reconstructions, and she was not happy with them. She felt that they were unnatural looking, and she felt that she physically felt as though they were uncomfortable and foreign to her. And I don't know there's a very small percentage of patients who have this problem. And I don't know whether it's a body image issue or whether they actually physically are feeling the implant move around in their pockets and have difficulty with that, coming to grips with that. But she elected to undergo removal of her implants. There was a fair amount of scar around her implants, and she had to have this access incision performed, which we don't normally do for free flap reconstruction, but this was done in order to gain access to her vessels, which were scarred, under a thick layer of scar along the medial aspect of her chest. And she had bilateral free flaps taken from her abdomen to reconstruct her breasts with her own tissue. Again, she's a BART train operator, so she has to lift herself in and out of her cab every day with a heavy pack, and she did not experience any abdominal wall weakness with this procedure. There are a whole host of adjunctive procedures that we perform after the initial mound is completed. Nipple reconstruction is the obvious next step and can be done in a number of different ways. This, combined with nipple tattooing, achieves a very three-dimensional approach. If you have had radiation of your skin flap and further surgery is not desirable, you can also undergo tattooing alone with variable pigmentation to try to achieve more of the three-dimensional quality to your tattoo. Other procedures include placing a contralateral breast implant for better symmetry. Fat transfer and liposuction has also provided a nice way to modify pockets and achieve better symmetry. This is a patient who underwent bilateral free flap reconstruction in Texas. She was then referred to me for fine-tuning. You can see that she has a lot of issues. She's had extensive chest wall radiation scarring. There is the left flap is larger than the right and is more elevated in position, and there's just more skin on the right side. And by doing all these little nip and tuck, basic plastic surgery procedures involving fat transfer from one breast to the other, skin excision, liposuction in various areas, along with nipple reconstruction, you can achieve a much more satisfactory result. Fat grafting, along with eloderm grafting, is also useful for correcting implant-related asymmetries. This is a patient with a very long torso and round implants. And we'll talk about anatomic implants that are coming on the market, which may make this sort of procedure less necessary in the future. But I'm sure many of you out there have round implants. And if you have a long torso, the round implant settles down into the bottom of the pocket and the upper pole tends to get hollow. There are ways to correct these areas of depression and asymmetry, and fat grafting is a great way to do that. Eloderm augmentation is another. And I'm just going to touch quickly on two more recent technologies that have come into notice this year. The first has to do with the introduction of the cohesive gel implants, which have been approved by the FDA in May of this year. The first company to achieve approval is Sientra, and this is a patient, these are photos provided by the Sientra Corporation. This is a patient who underwent previous reconstruction with round Allergan implants, and this left her somewhat deficient. She decided to undergo an exchange with anatomically shaped implants provided by Sientra, and achieved a more satisfactory smooth reconstruction with better upper pole filling and transition. And I think you're going to see more and more patients opting to use this in reconstruction. There are definite differences in the texture of these implants. These implants are firmer, which may or may not be an advantage depending on how sensitive the patient is to firmness and weight. The difference from a technical standpoint is that the polymer gel undergoes a greater degree of cross-linking, which makes it firmer and also makes it more shapeable and more form stable, so that you can create these shapes that won't then just settle down into the bottom of the breast pocket. Each company has its own proprietary method for achieving this. Allergan and Mentor, the other two big manufacturers, are coming out with their implants later this year. I think the FDA is slated to approve them sometime this month. The other technology that I wish to mention is rather controversial, and this is the Brava device. This was invented by Roger Corey over a decade ago as a non-surgical way to achieve breast augmentation. And basically, it's a suction cup device that you put on your breast, and you wear it for several hours a day, up to 10 hours a day, for several weeks to try to increase your breast size through a vacuum process. Once you take this off, your breast augmentation goes away. So Roger's been trying to market this device for over a decade, unsuccessfully. In the last few years, he's found a new application for the device. And what he does is, in breast reconstruction patients, he applies the Brava device for several weeks to achieve that soft tissue expansion, which is really just an increase in fluid volume in the breast, along with some vascular ingrowth. And into this expanded matrix, if you will, he grafts fat from other parts of the body. And he can graft larger amounts of fat than the average surgeon can achieve, and have the fat purportedly survive. So he can graft fat up to a cup size worth at a time. And with this technique, he is able to bring the patient back through several surgeries to achieve the volume that they desire. And when you look at his website, the photos are really astounding. And this patient had radiation to the right chest wall with mastectomy. And with this reconstructive method, she was actually able to achieve a C-cup reconstruction with her own fat and this device. Now, the average patient has to have serial surgeries over the course of 6 months to a year, with numerous episodes of liposuction and grafting. However, if this works, I mean, this is potentially a great method for people who have the fat donor sites to extend. There's no muscle surgery involved. There's no real painful donor site other than the areas of liposuction that are performed. So I think a lot of surgeons are starting to look into this as a possible option. This patient had a bilateral mastectomy and reconstructed with this technique. So in summary, these are some of my own patients who inspire me every day. I think that if you want to embark on breast reconstruction, just please know that it is a long process, but there's a light at the end of the tunnel. These patients have gone on to do marathons, take up new hobbies that they never would have considered before. And they're really an inspiration to all of us. If you choose to undergo breast reconstruction, please try your best to read as much as you can, but take everything with a grain of salt. Consult your plastic surgeon early. Ask as many questions as you can throughout the entire process. Don't be shy. And do your best to follow your specific surgeon's instructions. Try not to rely on blogs or the internet or even your best friend. Because every surgeon has developed their own particular idiosyncrasies, and their techniques work for them and their instructions work for them. And you may not